Hello and welcome back for episode 22 of the Noobie Dentist Podcast. I'm your host, Dr. Omid Azami, and in this episode, I'm with special guest, Dr. Stephanie Tran, who is an endodontist in New York City at Her Holiness the Pulp. We recorded this interview a few weeks back, and I just finished editing it, and I forgot how fantastic it was. This is pretty much a free hour of endodontic CE, guys, so I really do hope you guys stick with it, and really even have some pen and paper ready to take down some notes, because Dr. Stephanie Tran definitely does drop a lot of knowledge, and she goes through step by step, accessing the tooth, cleaning and shaping, and obturating. I want to thank everyone for their continued support of the Noobie Dentist Podcast and Instagram page. The numbers have been steadily growing. I'm getting a lot of positive feedback from the listeners, and it is quite awesome that I've been able to create this project and have it grow and reach so many people around the world. So if you do listen to it, and if you are a fan, please pass it on to your classmates, your colleagues, or your friends, so we can grow this thing a little bit quicker and try and reach more people. And we'll just jump right into this episode. I hope you guys do enjoy it.
Hello and welcome to the Noobie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Noobie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Azami.
So I'm here with Dr. Stephanie Tran, who's an endodontist in New York, who's kindly offered to be here for an hour with us to talk some endodontics. So Stephanie, thank you so much for being here. I just want to start off maybe with your origin story. If you can give us a bit of a short synopsis of your background, and then we'll sort of jump off from there.
Sure. So I was raised in California, went to school there, went to undergrad at University of the Pacific. And when I had decided to go to undergrad at Pacific, it was to do the accelerated program. So the accelerated program, they have a couple options, but I chose the fastest route, which is 2 years of undergrad. And I earned my bachelor's during that time, and then 3 years of dental school, because UOP is a 3-year dental school program. So a total of 5 years. So it was it was pretty crazy, but it was a really good, great option, because I knew from the beginning, I knew since I was little, I wanted to be a dentist. But what's interesting was that I'd come into school knowing I wanted to be a dentist, but I left school not 100% sure what kind of dentist I wanted to be. So my route to endo wasn't your straightforward, like straight from undergrad route. I had gone through dental school. I loved a lot of aspects of dentistry, and then I decided to go to GPR after, because I wasn't dead set on specializing at the time. I knew I liked endo, but there were a lot of parts of dentistry that I liked. So I just wanted to be a strong general dentist, at least overall, no matter what I decided to do. So I did a GPR in New York, and that's how I ended up with the New York connection. So I did my GPR in New York, made some connections there, decided to move to Philadelphia and practice general dentistry for a couple years there. And during those years, I knew for sure I wanted to go into endodontics. And we can get into kind of the reasons why in a little bit. And then I just applied to endo, and I attended University of Tennessee for my endodontics program. And that was great. So that was a 2-year program. And I had completed that this past June. Okay, so I've been in private practice in endodontics since then.
That's awesome. So you mentioned you knew from when you were a kid you wanted to be a dentist. Like, how did you have that connection? Do you have like dentists in the family, or is it something that you kind of saw and kind of were drawn to?
Yeah, so I wanted to be a dentist since I was young, partially because of influences from my uncle and aunt, who are both dentists, they're general dentists. Yeah, and I spent a lot of time with them, shadowing at their offices and seeing how they practiced, and I really enjoyed it. So, but I probably was really cemented my decision because I really liked art. As we know, as dentists, we work a lot with our hands, as well as the diagnosis and the science behind it. So all those things kind of coming together, and knowing that I really wanted to be involved in healthcare and helping our patients, those all combined to decide I really loved dentistry.
Yeah, that's pretty cool. And that's so unique that you had the opportunity to do like the accelerated program and then the 3-year dental program, because I mean, that's 5 years after high school. Most other people are like barely like finishing up undergrad by that point and then going into dental school. So you had the luxury, I think, of like after finishing dental school and doing your GPR of like still being like fairly young, right? So you can work for a few years even, and then do your specialty and still be like age-wise like ahead of the game a little bit, which is pretty cool.
Yeah, that was pretty nice. It was pretty nice.
Yeah, that's awesome. And then like the GPR situation, I've been talking to obviously a fair few people about pros and cons of doing a GPR. I know I've talked to you over Instagram and you've mentioned you enjoyed it a lot and had a lot of like oral surgery exposure, which you found pretty exciting. And I know a lot of us like oral surgery as well. So tell me a little bit about that GPR year, like what kind of things you learned and some of like the major like pros and cons of it.
Oh yeah, so my GPR was a really great balance of both hospital dentistry and clinical outpatient dentistry, the normal like day-to-day clinical stuff that we see. And for me, GPR was what really cemented that I loved endo because in my GPR program, so the hospital part means that you're on call as well as hospital rotations. And the on call, a lot of it was a lot of the things that I will now see in endodontics. So severe pain, swelling, acute abscesses, and trauma. And so because I got to manage that, I actually realized I really liked it. Some of my co-residents, they didn't, but I happened to really like those aspects of being on call.
Yeah.
And then also what was interesting about the GPR was I came at the GPR being really terrified of surgery to start with. I didn't have as much experience in dental school as I would have liked. It just happens to be that way with my patient pool. So I left dental school having some surgery experience, but just being really intimidated by surgery, being really intimidated by placing incisions and flaps and taking teeth out. And stuff. But then in residency, it's nice because you have a lot more independence than dental school.
Sure,
you have the independence to make treatment planning decisions, but you have somebody there to guide you and to help you out if you have any questions on things or if you're not sure about technique or whatnot.
The safety net is nice to have. Like you can take on a bit more.
Yeah. So that part was great. And so that's why I ended up doing more surgeries because I was, interested in doing them, but I really liked I had that guidance. So was able to do perio surgeries, more oral surgery, surgical extractions, that kind of thing. So it made me more confident in leaving my GPR program and practicing general dentistry.
And when you finished up your GPR, like, did you know you wanted to do endo, or that's something like over the couple of years of private practice you kind of developed or sort of solidified in your mind that was the way you wanted to go?
I was pretty sure at that point that I wanted to go into endo. And so when I ended up moving to Philadelphia, it was perfect because Philadelphia is a really big CE course, really big hub for endo CE courses and endo speakers. So I had gotten to know some of the residents at the other programs, and I sat in on a fair number of CE courses, talked to the directors, even did some externships at their programs.
That's great.
And that just really solidified it for me that I really loved endo, the educational aspect of it as well, in addition to actually doing it.
That's perfect. So in your first year, obviously with the Noobie Dentist podcast here, like it's more for, new grads and dental students and everything. So in that first year after your GPR, how much endo were you doing like in your private practice? And what was like your sort of like, and obviously like you're interested in it and presumably like you're like, reading up on it and going to courses like you said. But like clinically, like how comfortable were you and how frequently were you getting to do some endo treatment?
So I was able to do a fair number, probably not quite as many as I would have liked because the private practices that I was working at were more for like underserved communities in Philadelphia. So I actually did a lot of extractions. That's why I became so comfortable with
like
surgery.
Where I'm at right now. I want to do more endo, but everyone's like, just pull it. I'm like, are you sure? Please, let me just do endo.
Exactly. So I ended up that was another factor. I ended up becoming really comfortable with surgery because of the patient population, because of those treatments I was doing. So there was actually a teeny part of me a small part of me that considered going into oral surgery. That I was almost going to reconsider my decision of going to endo. But with endo, it's nice because I got to make the decision of whether or not I felt comfortable treating it. So I got to do a fair number of them. It helped though that I did quite a few in dental school, and my GPR, I asked them to tailor it towards doing a lot of endo. So they scheduled me a lot of endo patients, and my co-residents would pass me a lot of endo patients.
That's great.
So that helped a lot. That built my skills too before I even got into private practice, and so I was able to feel really comfortable about doing a lot of the treatment.
That's perfect. So I wanted to, and then I think just something that I wanted to do a bit more so of going forward is get a little bit more clinical, so people listening can actually get some value out of the guests that are coming on and
Sure.
tap into their expertise a little bit. So what I want to sort of do is like set up a scenario and kind of get you to like walk us through it. So you've diagnosed like a lower first molar for irreversible pulpitis that needs some endo treatment.
Mm-hmm.
The first question I have that I found myself too, which is I want to actually ask you is, a lot of times the patient comes in, their symptoms are like pretty like as soon as they're telling you their symptoms, like, okay, yeah, I know what this is. And then you obviously you tap the tooth, it's tender. You put the endo ice, and it's like prolonged sensitivity for a while, so you're pretty confident with the pulpitis and apical periodontitis like diagnosis. But I find in these teeth, when I actually access it, it's like necrotic. Like there's no blood, it's not hyperemic. So like what is like what's happening there basically? What do you think?
Oh, so do you find a little bit of tissue in there though? Like, or you're talking about, because there are going to be teeth where you can have a little bit of sensation, but the amount of tissue can look very, very minimal. So you're not always going to have a lot of blood. There's going to be cases where a tooth is really hyperemic, but then there are some cases where the tooth has those symptoms, but because of like calcification and whatnot, the amount of tissue in there is actually pretty minimal.
Yeah, because I'm always surprised. I get in there expecting to see like this blood work, and it's like dry. I'm like, what's going on? Like,
yeah, exactly. So it actually can be just very, very minimal tissue that's left, and then but the ones that are like super necrotic, like there's a lesion on the radiograph and everything, those are usually like very, very empty or with purulent exudate in it.
For sure. Okay, so what I want to do is because obviously endodontists, because you guys do this all day every day, you have like a set sort of like routine that you do, right? Like you access the tooth and you have like a certain sequence, right? So I was hoping if you can share that sequence with us, because I find like in my offices, and I think a lot of associates, obviously if we're working out of more than one office, there's different like endo systems and everything. So you kind of got to get familiar and comfortable with like, maybe like it's like a wave 1 gold, or it's like a pro taper gold. So there's a little bit of adaptability and like learning got to take place. But so I want to see if you can maybe just walk us through, like after you've accessed and you found your canals, sort of like what's your sequence? Like do you prep each canal like separately, or kind of like do like go get your working length with each one and then kind of go in sequence? Or so if you just talk us through that sequence, that'd be pretty cool. I think it'd be very valuable for the listeners.
Would you want me to go over how a little bit about access itself?
Please.
I find that access is actually the most important part. Like that sets you up for success.
Okay, let's do that. Really. So let's say it's a lower first molar. So if you can just maybe just talk us through like after you got your dam on, and then go from there. Sure.
So the way I proceed with access is really by looking at the root bulges. So it's looking at the CEJ. Yep. The occlusal table will lie to you. Teeth can be slightly tilted. Teeth can be, as we all know, they can be tilted. They can form where it's slightly tilted, like lower premolars will do that, right? Where the occlusal table is really, really lingually
inclined,
facing. Yes, exactly. So with teeth, we know that they develop from the inside out, right? So the pulp is right in the middle. The pulp being right in the middle means that the CEJ, the shape of it will tell you exactly where the pulps are. So how we were taught, and how we were taught really well, I really appreciate my directors did this. They really focused on evaluating the root bulge. You could do this by probing. So you've already numbed up the patient. You can even do this before you have the dam on. So the tooth is nice and numb. You probe around the tooth and you feel for where the root bulges are. Those root bulges on the direct buccal and the direct lingual will tell you the center of where the pulp should be.
Okay, that's pretty cool. Yeah.
So that you do that first. And then where you should start accessing is not so much in the direct center necessarily, but the mesiobuccal pulp horn, especially when you're first like getting used to doing endo.
Yeah.
I mean, you see those crazy accesses by endodontists, but that's, that's after a lot of experience, understanding and stuff like that. Yeah. So for beginners, the best thing to start out with is the mesiobuccal pulp horn. That's going to be, you're going to be like a third of the way with the occlusal table and from the buccal. So if you start with the mesiobuccal pulp horn, the reason is because studies show that the mesiobuccal pulp horn is going to be the highest pulp horn and the most obvious for all of the pulp horns. Okay. So it's going to be the easiest to find, even in a slightly calcified case. Mm-hmm. So that one is going to tell you, you're going to hit that one first. Then you can draw your occlusal table map. Yeah. So sometimes it's actually easy to start off when you're accessing, rather than going straight all the way to the bottom because you're not really sure how deep things are sometimes. Yeah. You can draw yourself a little map like 2 millimeters deep.
Okay, like you're prepping like a occlusal cavity prep kind of, and then...
Exactly. So it's going to be kind of a trapezoid shape where you're going to mark where the pulp horn should be according to the root bulges. And you can even make little dots. That's how I would teach my dental students to do that. You can make little dots, and then you can connect the dots to make a 2 millimeter deep.
And what burr? Are you using like a round burr for this, or?
No, an 1157. So it's a round bottom. It's a rounded, longer... carbide burr. Okay. So kind of like a cylinder burr, but it has a rounded bottom on it.
Okay, cool. 1157 burr.
And then after you figure yourself out and you make that shape, you can follow that shape, and that you should be able to hit all the pulp horns from there. When you're doing it, you can keep an eye. The best thing to do is keep an eye on the length. We know from the way teeth develop, it's going to be about 6 or 7 millimeters from the occlusal table to the pulp chamber. So you don't ever want to be past 7 millimeters.
So
if you're deeper than 7 millimeters, there's a good chance.
The pulp chamber? Or?
Yeah, to the pulp floor. So if you're past 7 millimeters, you're not in pulp. You're probably,
Okay. That's when the heart rate goes up.
Yeah, exactly.
Okay. So you do that. And then what's your next step?
So let's say now you found all the pulp horns. The big thing to do with lower molars is not be too lingual, because it's very easy to face it to be too lingual, since the occlusal table is usually a little more lingually inclined, and then you're too lingual and you can perforate out the lingual. So that's a big tip. So let's say you found all the canals, orifices. I usually, if it's not necrotic, I will put in a file just to make my glide path, so like a 10 file usually. And the big thing to do is you don't have to twist it in, but kind of you're gently twiddling it in. So you're like twiddling back and forth to guide the file down the canal. And that's just to see if you're kind of loose and see if you're at a fairly decent working length. And that's based on your estimate of what the working length should be based on your radiograph. Then after you've made yourself a glide path, you can then start using orifice openers. So starting from a larger but wider taper file, so like a 2508 is usually a good file to start with, and you're not trying to take it to length. It's really just a little bit, just the occlusal third, the cervical third of the canal system.
Yeah. So is this like similar to
your file?
What like an SX file would be? Is that like a 1W?
I would honestly not use an SX, because an SX has such a thin, fragile tip that they're super prone to fracturing if you're not careful with them. Yeah, SX is very, very prone to fracturing. So something like really even the profile or the K3 files, I know they sound super old school, but they make some really great orifice openers that have landed edges. So that means the blades aren't sharp like a pro taper, but they are blunted on the sides. So they aren't as aggressive, and they're great because just right in those initial first few millimeters, so the occlusal third of the canal system, you don't necessarily need to go down super far. It's just to make yourself a little opening that guides the subsequent files down the canal. So you always want to kind of the canals in like thirds. So there's going to be the cervical third, middle third, and then the apical third. So the cervical third, you're using slightly wider tapers. I know an 08 sounds like a huge taper, but you're only taking that for the very, very occlusal, the very top of the canal system. And then you can treat the middle. That's usually like an 06, but not a huge 06. We're not talking about like a 45 or 50 06. This is like a 30 06 or 25 06. And then to finish it off, you can finish off with an 04 taper. So that's usually my general, that's a sequence that I would teach like any general dentist to do. It's a systematic way of approaching root canals.
So because obviously, and I'm guilty of this like myself, is like we rely on like the system, right? So we have like the SX, S1, S2, F1, F2, and we just like dumbly just follow the colors. Like it's very dumbed down for us, right? So with this like 2508 and then like 3006 and then finishing with the 04 taper, of the common like systems out there that most like associates would have in their practice, what would this be most closely like replicated by? Which system would you recommend?
So there are certain systems that will have all the shape sizes. So that would be like a K3 or profile. Those are very old school shape. Those are very old school systems, but they're very good for pretty straightforward cases because they are landed files. They aren't super aggressive and they're not super large. The pro tapers, the S1 and S2 are great files. Those are ones I use in my own cases system pretty regularly. The SX is a little aggressive to take down that far. It can be good for the very cervical third, the very top of the canal system, but they are sticky for any kind of curved canal system because if you push on them too hard, the apical tip is very prone to fracturing.
I'm scared of that.
The F1 and F2 files are so, I'm sorry?
I said I'm scared of using the SX now because that's like my go-to. Like I love that thing. So it's good that you mentioned this. I gotta be a bit more careful.
It can be good, but you just gotta be careful with it. It's going to be a little bit more prone to fracturing if it's a really curved canal system. B2 or something. They can be really good, but you have to be careful with them. Then the F1 and F2 are okay, but any larger than that, the issue is that the taper on like an F3, F4, F5 are very, very large. And so you can be taking away a lot of tooth structure if you're trying to use it in a smaller canal like mesials of lower molars or the buccal canals of upper molars or any premolar, really. They're so large. So the F series is really better for maybe anteriors, a fairly straightforward canal system. Wave 1 is a very good, solid system for a lot of people to use for straightforward cases as well. The only thing is that a Wave 1, having the whole one-cell file system isn't the best thing for a lot of not all canals at the same size, right? So that's about the wave.
So it doesn't leave you much room for like wiggle room, right? Like if it doesn't work, it doesn't work, and if you don't have anything else, then you can't really like get through that canal. So that's a tricky one, right?
Well, no, calling it a single file system is a little bit of a misnomer because it actually comes with like larger files for larger systems and smaller files for smaller systems. The primary so it ends up being multiple files. You have to use exactly. So if you use those, a lot of times you end up having to use the smaller file for those like really large palatals or an anterior tooth or something. So it's a great straightforward case type of file, but it's not necessarily the best case or maybe the best thing to approach a really complex, very small calcified case.
And so in this sequence that you just mentioned, go ahead, sorry.
I was just saying, so systems from profiles, K3s, those are pretty good, but you just have to be careful with some of the files because they can get really, really large.
And at what point in the sequence are you like measuring your working length? Like, because it obviously said with the 10 file that you initially go, you're kind of going to your estimated working length that you kind of got from the radiograph. So when in the sequence are you actually like fully getting your accurate sort of working length with your apex locator?
After the orifice opening.
Okay. So you put the 10, and then do you do that with like a 15 hand file, or you still just use your 10?
10 or 15, just depending on how tight the canal is. If it's really, really loose with a 10, I'll use a 15 because it's always better to take your working length with a file that's slightly binding in the canal system. So usually a 10 or 15. If it's something that's too large, the problem with that sometimes is that those larger files can be too stiff to get around, and then you can accidentally ledge.
Yeah. And then what do you use, like a Pro Lube or like any sort of similar lubricant like in these initial steps, or are you just irrigating throughout?
Because especially a lot of them have substances that will react with the hypochlorite. So when you rinse out subsequently with hypo, it actually effervesces. So it brings up a lot of the debris and everything.
Okay.
But there are papers clogs up the flutes. So what happens is that, you have the lubricant in there, which is good. It has EDTA, chelates, all that stuff. If you don't stop and wipe your files and rinse out really regularly, it can start to it starts using the debris from the tooth structure and combining with the lubricant, so it's clogging up the files, and when it clogs up the files, you're actually putting too much torque in the file, and that can make it prone to fracture.
Okay, that's a good tip. So you gotta make sure you take it out and wipe it down every time.
Yeah.
Okay, and then do you use do you use the lubricant like throughout the whole thing, or just for the initial like orifice opening, and then you kind of just switch over to using like the irrigants to keep the canal like wet?
I actually don't use a lubricant that often. I use my hypo as kind of a lubricant. So I'll fill the canal system a little bit with hypo, so that way I'll just take my files in through the hypochlorite.
Okay, that's pretty cool. And then obviously like a lot of like videos and a lot of techniques recommend like between each rotary file to like obviously irrigate and like recapitulate with like a hand file. Is that something that you recommend doing as well?
Absolutely, 100%. So at least between every file or two. You can get away with 2 files, especially if you're not moving very far. But recapitulating, using the smaller file, usually like a 10 file, that you take not just the working length, but maybe even like 0.5 millimeter or a millimeter past working length, and then just wiggling that up and down, that just really removes and dislodges a lot of the debris to get into the hypochlorite too.
Okay, that's perfect.
Yeah, so it's important.
So let's talk about obturating now. So you've prepped everything. You've done your shaping to length, and then so what's your final irrigation sort of like sequence? Did you use like a Q-mix, EDTA Q-mix kind of thing, or like a BioPure or anything like that before you like dry the canals?
Yeah, I'm very good. Has a lot of good research behind it. EDTA is excellent. So we don't recommend chlorhexidine anymore. Research did. So some of the previous schools of thought was to use all 3. Yeah. Chlorhexidine is a good disinfectant, don't get me wrong, but it has a couple of issues that it can react with the other irrigants a little bit, but more importantly, it is not tissues, and so that's why we don't even recommend using chlorhexidine for revascularization type cases. And in general, the hypochlorite and the EDTA do everything for you, so you don't need that third step of the chlorhexidine. The EDTA chelates, so it removes the smear layer, it chelates the inorganic material. The hypochlorite removes the organic material. So the best sequence, though, like your ending irrigation sequence, is to do a full thing of hypochlorite, then EDTA, and then as a final rinse, hypochlorite again. And the reason is because the EDTA is acidic, so it can affect the walls a little bit. It's better just to rinse everything out again with hypo. Okay,
nice. Yeah, that's what we were taught in Melbourne as well. That was like the sort of sequence. And so what's your, and we had a few questions about this, obviously with the obturating. A lot of the offices now are, going towards like the heated carrier sort of model with like Guttacore or like Thermofill. So what do you use, and then what are your like different opinions about the different techniques, and basically like what do you think gets the best result, and also like keeping in mind that if a case does fail, like in terms of retreatability, I know I've been hearing like the Thermofill, like my endodontist that I work with, She hates thermophil because it makes retreats quite hard, she says. So what's your sort of experience and your thoughts about the op training systems?
So in my residency, we were taught pretty much every file system and every obturation system in the book. They wanted us to really be experienced with all the different methods and all the different techniques so that we could evaluate them. Honestly, the warm vertical is my favorite. That's the one that a lot of endodontists use. So that's where you take some sort of heated tip, either system B, heat, whatever. It doesn't matter the brand, but a heated tip, you take it down to about half. They say to within 5 millimeters, no more than 5 millimeters from the A.
Okay. Yeah.
Thing is, though, most canal systems are too small to take that far down the canal system. So you really, let's say, as far as you can, let's say wherever, as far as your heated tip can go. What that does is that heats the gutta percha and helps it fill all the nooks and crannies and everything. Then you backfill it with some sort of heated gutta percha using some sort of backfill system. Obtura is the classic one, but you also have Elements obturation units, and Calamus and whatnot. They're all good brands.
And are you doing this like in increments, or or is it just like as your experience with it goes up, you can fill the whole canal like in one shot, or is it better to do like small increments and like pack it again and then?
It's always better to do it in small increments. So do it in about 2 to 3 millimeter increments, and really that you're only doing that 2 or 3 times, right? The amount of increments you're doing. So it doesn't take that long at all. And the reason is because sometimes when it's a really large canal, it can get caught up with an air bubble, and the air actually cools the gutta percha down a little too quickly. And sometimes, so that's how you get those voids.
Okay, cool. Yeah. I've seen those. And then, and that's like, that system is like pretty easy to clean up as well, right? I think that's like one of the like advantages of it. Like the chamber is like pretty clean once you finish with that sort of technique versus like the gutta core and stuff. Like I find it creates such a mess, and it takes like a long time to sort of get that chamber clean afterwards.
Exactly. So the thing about the gutta, the warm vertical technique, that technique is great because it's very easy to clean. It's very easy to compact it. It does get into a lot of those laterals and spins and whatnot quite well if it's done well, and it gets it done better than say a cold lateral technique. Yeah. Cold lateral is the way a lot of schools teach.
That's what we taught.
The reason is because it's a very good, solid, well-published, well-understood technique. It's very solid. With cold lateral, it just doesn't fill maybe all the 3D anatomy quite as well, but it might not be it, and it might not get laterals quite as well. But for a very simple, straightforward case, it's a great option. So with warm vertical, that's my favorite. Cold lateral, I don't do that very often. And you just have to be careful with cold lateral that you don't push the spreader in too far, because that can cause a lot of stress on a tooth and make it more prone to vertical root fractures. Yeah, exactly.
Okay, perfect. And so what tips do you have? Sorry, go ahead.
Oh, sorry. You were asking about thermophil. Yeah. So the problem with thermophil is that it sounds like a great option, but number one, like you said, it's very difficult to clean. Number two, it's very difficult to retreat. Gutta core, yes, it's made of gutta percha, but the core gutta percha is not the same as the outside gutta percha. So the two of them actually they aren't bonded that well. So you have that issue between the two layers. Yeah. And then also the core gutta percha doesn't dissolve in our normal solutions. Yeah. Doesn't dissolve as well. So trying to remove it is not as easy as we'd like. It's not as easy as normal gutta percha. Yeah. And then the issue with thermophil, it's a beautiful technique if it's done well. It's actually the most technique sensitive of all the obturation techniques. It's a great technique for filling 3D obturation, of course. Yes. I mean, Johnson developing that technique, it's a great one. It really gets into all the nooks and crannies, but it's so easy to mess up. It's very easy to push gutta percha out the apex, like way far out the apex.
For sure,
And it's also very easy to make it too short because sometimes you don't know exactly how far you're pushing, etc., or the gutta percha cools down too quickly, and then you're too short. And then you can't even pull a cone out the way you can with warm vertical or cold lateral. You are kind of stuck. Then you have to try to retreat it.
Man.
And then with with the metal and plastic thermophil carriers, they're just really difficult to remove sometimes. So, if the metal carriers are cut down too low, they are near impossible to remove.
So, do you recommend, with like thermophil or the metal, like the plastic ones, is it better to leave like the core, like maybe 1 or 2 mils outside of the orifice? So it's like something to hold on to or grab if a retreat's needed, or?
Exactly. So that's actually required for the metal carriers. You have to leave at least a few millimeters up into your core buildup because otherwise it's impossible to retreat. With the plastic carriers, it's very hard for you to leave it. So then what ends up happening is that most people usually cut it down, which is fine. But with plastic carriers, those you just have to use different methods to try to get them out. So they're just very difficult to get out. It's doable, and sometimes they come out really easily, but a lot of times they can be very difficult.
Yeah. Okay, that's pretty cool. And then so that's done. So that's pretty thorough. I think that's amazing. Thank you for like going through that technique, because that's like pretty much like a nice little endo lecture for everyone to get the review. So in terms of that's like actually like this is like useful for me. So I'm sure other people, because I'm writing down notes here. So I have like a full page of notes now, which is nice. So in terms of like clinically for new grads to gain some confidence, I know like the like American Association of Endodontics has sort of like that radiographic assessment sort of like tool to like determine how easy or hard like a case might be, just based on like the PA that you might take. What tips do you have for like like your first like 10 cases? Like what kind of stuff should you be looking for, and what kind of stuff should you like what red flags on a PA that you might see, or even like a patient that you might see that it'd be like not a good case to start with or to attempt in your first like 20 or 30 cases?
Yeah, definitely. So anteriors, especially ones that are not too long, so basically centrals or laterals, and lower premolars that you're 100% sure they're single canal, those are the best ones to start with, because the canal systems are going to be fairly straightforward, they're fairly straight, and usually you can tell whether or not they're calcified, and also find back the chamber more easily. You're not looking for necessarily multiple canals, whatnot. So the big things to keep in mind are if you have a receded chamber or receded canal system, that's where it looks a lot thinner. The canal systems have some calcification. It's not as clear and wide and dark as other canal systems. Secondly, for the pulp chamber is how far from the occlusal table the pulp horn is. So if it's really far down there, chances are it's even harder to find, especially without a microscope and experience of knowing where to look, because a calcified case is very, very daunting. And then another thing is to know whether or not there might be a second canal that's coming like a deep split, or where there is a second canal is looking for what's called a fast break. That's where you could see the canal in the cervical third, the very top of it, but all of a sudden it kind of dissipates towards the second half. That means that there's a good chance there's either a second canal where it starts out as one and becomes two, or it just it has this really thinned out, becomes like a little bit more calcified. So lower premolars are a little bit prone to that, where you'll see the pulp horn more obviously, but the canal system might be a little bit thinner. So you just look for
some scary lower premolar radiographs that I see like on Instagram with like it kind of splits off into like 3 canals. I'm like, oh my god, like I don't want to be stuck doing that. So that's, like you said, you gotta be sure if there's like definitely one canal in there, not those like crazy like apical third like anatomy on those ones. And
exactly. Oh, and then looking at the apex. So looking to see if there is a quick little, like a dilaceration, or becomes very thin. So upper laterals are very prone to this, in that the apical third will curve more acutely. And that can be really hard, because when the apex of a lateral is often really thin and really skinny. And so if you're using a file that's too big, it will be really more prone to transportation or even perforations.
Yeah. And then, so just one question I had was, so say if you're like working on a multi orifice tooth, like a lower molar again, are you like the sequence that you kind of went over with like the 10 and then the rotary files, are you doing like, do you drop your 10 file in each canal and then do the orifice opening in each canal and then kind of do it that way? Or do you like finish one canal and then finish the next canal and then finish the next one kind of thing? Like what's your preferred method?
I do all the canals at the same time. I don't do it one by one. For the 10 file, that is really important to really try to wiggle it down. And then what you do is not just guiding it down, but you wiggle, you kind of counterclockwise twist, so you kind of get it a teeny bit loose, so you back it out maybe 1 millimeter or 2 from where you had it, and then you rasp it up and down, and that gets you a glide path that loosens the canal up a little bit so that you can guide the files in more easily. So that's how you do it. You're kind of rasping it up and down.
Yeah, that's perfect. That's awesome. Thank you so much. So what I want to do to finish up with is sort of do the mailbag for the questions that we got on Instagram for today, if you don't mind. So the first one I have is from Daryl Turkilis. He was actually an earlier guest on the podcast. His Instagram is Barbells and Burrs. And he was asking about like the efficiency of like thermofill system, which we kind of touched on. But the other question that he had was like the single cone obturation, which I think maybe comes into play with like systems like Wave 1, where the master cones are like matching taper to the Wave 1. So theoretically, I mean, they should fit pretty snugly, right? So what's your thoughts on that sort of obturation system, where you're not really backfilling or you're not really like laterally condensing, you kind of just put the one cone in and just like seal it up at the orifice?
The problem with the one cone system is that most of the time a canal is not a perfect shape. I know we may end on a perfect shape, but the coronal third is often going to be a bit wider, and the middle third might be a bit wider than the apical third. So basically, it's a bigger taper. Yeah. Since it's not all one taper, the cone isn't actually obturating as that much space. And you are going to be a little bit more prone to having some voids. And when you have more voids in between the cone and the sealer, or the sealer and the wall, then it's going to be easier for bacteria to travel down and leak through the obturation system. So that's the problem with a true like single cone and nothing else type of system. Now that can work for very thin canals sometimes. There's going to be, so this is going to be a little bit of a debate amongst the endodontic community. Because the thing is, if you look at the warm vertical system, when you down pack, we're not actually down packing, to 3 millimeters from the apex or something like that. Most people don't. You're usually down packing as much as you can. So that's usually to the middle or so of the canal system. That means, if you think about it, everything after that, everything able to that is basically a single canal, so a single cone. So, there is some merit to it, but with a big asterisk. And that is, if your canal was really small to start with and you didn't have a larger taper in the occlusal at all, so a very thin canal system. And the other big asterisk is you have to use sealers, and plenty of it, but sealers that are not going to really dissipate too much. So ZOE sealers, like our tried and true, like powder and liquid type ones, those are great. There's lots of research behind them. They go away. Some people who don't like the puffs, it's great for that because the puffs go away. But they might not seal as well, or they're not sealing like everything, but like they aren't quite the same as a bioceramic sealer or a resin-based sealer. So resin-based, like AH+, a lot of people use that. That's kind of like the most published of a lot of the sealers besides the ZOE sealer. So a lot of the research between AH+ and bioceramics is going to be pretty similar. Bioceramic is super useful in a lot of situations, but as a pure sealer in and of itself, the the problem with bioceramic is that you can't retreat it that well.
It's hard,
If it's blocking the apical third, that's it. It's empty. It's essentially almost the same thing as MTA. So you've blocked out the apical third. You can't get past it. So, but it does go into the tubules and everything very well. So there's some pros and cons to it. There's pros and cons.
And on the topic of the sealer, so when you're obturating, how do you apply the sealer? Like, do you put it on a paper point or something, or do you use like a hand file, or do you just kind of use it on the cone and with the master cone and put it in that way?
No, for me, I like to have plenty of sealer. I like puffs. There's the whole puffs versus no puffs thing doesn't matter all that much, but I happen to like puffs. I really like to make sure it's sealed, and I have a lot of sealer in there. So I actually take a paper point, I coat the canals really well with sealer, but then if it's a thin canal system or a really long system, sometimes even the cones don't get the sealer as far as I would like. So I actually coat a 15 file, set it at at my working length, and then take some sealer onto it, and then guide it down the canal so that I can seal even the apical third as well. Yeah. So, but for the single cone system, it's possible, but with a big asterisk, and that's based on sealer type, making sure that you don't have voids, and depending on the canal system. So if we're looking at an anterior, where those are huge, I mean, we've seen that they're really large canals, a lot of them, I wouldn't recommend it for that, but like an MB2 or really thin premolar or something like that, there's a single canal, a single cone is not going to change your outcomes that much because it's already so well fitted.
Perfect. Yeah. So the next question we have is from Dr. Khalil. He's based out of Egypt. And so he had a multi-part question. So the first question he had is, how many times would you retreat a tooth?
Depends on who had done the retreatment first. So let's say this tooth had a retreatment, yes, but the retreatment was of a tooth that was barely treated to start with. I wouldn't mind retreating again, but I wouldn't do it more than twice. And if he and that's if he meant non-surgically. But usually our standard protocol is first a retreatment non-surgically, and then apical if it's not healing as well as we'd like, or if we weren't able to achieve our treatment outcomes, meaning like, let's say there's a separated instrument in there and I'm not going to be able to remove it. There's just no way. And it's associated with a lesion. In that case, I would do the retreatment and an apical because I want to make sure that the inside of the tooth is really, really clean. And then I would also clean out the outside using an apical.
Okay, that's pretty cool. And then he's also asking, how much magnification do you normally use for your cases? Are you using like a microscope always, or do you ever just use your loupes? Or
so 100% under a microscope. I only do a few things not using a microscope, and that's like putting a dental dam on and anesthesia because I want to have my landmarks. But other than that, everything is under the scope. There are endodontists who don't use microscopes, but again, that's because not because they don't need a microscope in and of itself, but because they already have the experience of knowing what to look for and where. So that's the biggest thing. It's not just having a microscope, it's also the training and the experience of knowing how to look for everything and knowing what to look for.
Okay, that's great.
The actual microscope magnification, I use a Zeiss microscope. It's a 5-step microscope.
What's that? Is that like 10 or what's the magnification on a microscope? Like the ranges?
I can't remember off the top of my head. It's ranges because there's 5 steps on it, and then the actual optics themselves have some magnification. So the little knob on the outside, that's not the true total.
I'd love to like try it once just to see what it look like, how a tooth looks. Like I wonder how much like more you can see. Must be crazy. What about when you're in private practice? Like, do you have just like your loupes back then? And what magnification did you use if you didn't have a microscope when you're like in private practice?
So I used the 3.5x loupes when I was in private practice. But definitely the change from a loupes to a microscope is huge. The world of difference because I'm not working under like 20x magnification at all times, but I'll use it to look for a separated instrument. I'll use it to look for another canal, or it helps me find like a deep split or something like that. Like those little clues. That's when I'm turning up the magnification either to the highest or the second highest.
That's cool.
But I'm usually working, like just doing my regular work under the lowest or second lowest.
Okay, that's pretty good. It must be like a bit of a learning curve, like to get comfortable using it, right? The microscope.
It is. It is, because you remember from dental school, there was a little bit of a learning curve just to learn the using how to prep and everything with loupes, and then how to do direct vision with loupes, right?
Yeah, for sure. Yeah.
Mm-hmm. But I mean, definitely take a look at it. A lot of places, a lot of endodontists will definitely let you take a look through their microscope.
That'd be cool.
See,
that'd be nice, because I've seen there's a few like dentists on Instagram that I think they're like in like Singapore or Malaysia. Like Gria RR. I don't know if you've seen his profile, but he uses like a microscope for like restorative, which is pretty cool.
Yeah, there are a fair number in California and I think Texas and stuff who do it. Their margins, the margins are amazing.
I feel so bad about myself every time I go on Instagram. It's like, so his final question was, how many times have you broken a file? But I think how I want to frame the question is, if a general dentist breaks a file, what's the best way, do you think, of managing it in terms of like communicating to the patient that this has happened, and knowing like when to even attempt to retrieve or just to like stop right away and refer it off?
So I wouldn't try to retrieve a file as a general dentist. There are so many things that you need to try to retrieve a file. That's actually really hard to do it with. You need an ultrasonic, and it's going to be an ultrasonic that like the endodontic kind. So it's actually meant to prep away tooth structure, and you're using it very, very delicately, because it's the most conservative way of removing tooth structure to actually access the separate instrument. Another thing is that's whether or not you can see the instrument. If an instrument is past the curve of a canal,
there's no way.
If you the rule of thumb is, if you can't see it under a microscope, you really can't retrieve it. You can't take out what you can't see. So it makes it really hard. Additionally, sometimes you need extra little tips and tricks of getting these files out. There's a million and one different ways of getting separate instruments out. So I wouldn't do it as a general dentist. I would really, really hesitate. There are too many ways to perforate the tooth. And then, the tooth, unfortunately, is done for. Now, if it happens, and let's say it's just the very apical third of it, that's very difficult to retreat. I wouldn't even retreat most of those a lot of times, depending on the situation. But a lot of those you can't retrieve. The risk of removing excessive tooth structure and then causing either a perforation or too much risk to the tooth is so high, that's better just to leave them. So if they're already at the end of the treatment process, so like you've already done most of the instrumentation and irrigation, the research has shown it doesn't significantly cause an adverse reaction. Now, that's not to say that we should just be breaking files willy-nilly, but don't feel horrendously bad if sometimes you have to leave one in.
I was talking to my one of my friends, and we're talking about like those cases that you see maybe like on Instagram or on Facebook, where like the dentist is like separated a file in like one canal, and then they've gone on to like treat the other canals and like separate another file. It's like, when do you stop? Like, you gotta, it's crazy some of the stuff that you see out there.
That's true. It's probably trying to refer early to your question. It's probably best to refer early.
Next question I have is from Dr. Kaz, who told me to tell you he's a big fan. He's amazing. Like, he's such a purist. Like, he loves his literature. His question's like a bit technical. So he's asking, like, he's noticed based on like your posts of your cases that you put up, he's noticed like variable like tapers on your finishes and your obturations. So he's referencing like Steve Buchanan and Martin Trope's papers. So he wanted to see what your rationale was for certain cases of going to a larger taper versus keeping a minimal taper in some cases.
I really tailor it to the tooth. Does he mean variable taper within the canal system or with
case to case? Like you'll notice like on some of your fills, like you've taped like it's a larger taper on the shaping, and then in some cases it's like a smaller taper.
Oh, okay. Yeah. So I try to tailor my cases to the tooth. Each tooth is going to be a little bit different, just like an MP2 is going to be different than a
Yeah.
palatal. So I'm not going to be as aggressive of putting like an O6 taper on a MB2. So uh, let's say it's a really curved case, and so something with a larger taper is going to also be a bit stiffer,
Yeah.
right? So if it's a really thin or really curved case, I might not necessarily want a really large taper. Or if a case has a really severe curve or a really difficult access, I might have to use a controlled memory file that so like one of my favorite systems is Edge Endo. It's a great system. Also, you were asking about different
Yeah.
systems. Edge Endo, very
Yeah.
solid system. It has very thin tapers though, so it's a little bit difficult for a lot of people to obturate at first. You may have to finish on a different
Yeah.
file, but because it has a maximum flute diameter. So the nice thing about Edge is that it is extremely flexible, which means I can pre-curve my files. It holds a curve rather than flicking back to a straight
Yeah.
file. It holds the curve, and so I can guide it into a really curved case or a really difficult access. Like sometimes I keep my accesses smaller, or if it's a small opening, like a person can't open that
Yeah.
wide. So sometimes I'll use those files and finish on those files only, which means that those have very, very small tapers.
Mhm.
So it's going to be a combination of a couple of factors of the tooth, if the tooth is very thin or very curved or very calcified, and then also with if the access of it is difficult.
Okay. So if it's a more curved or difficult access for the tooth, you prefer to go with a smaller taper because the file itself is going to be a bit more flexible to allow it to negotiate those canals. Is that right?
Exactly. And then some canals just happen to be a lot larger. There are some palatals and or anterior teeth are going to be much larger. So it just happens to be that they're going to be a large taper. I'm just going to end it that way. I'm not going to try to conform all my canals to a certain size.
Yeah.
And a lot of the papers that he's quoting, like Trope, those are based on the size of the apex. So the 4004, that's the classic one,
Yeah.
or 3004, 3006, depending on the paper, whatever paper you're reading. That is so that you're guiding enough irrigation
that's right.
solution to the apex,
Yeah.
right? So he's absolutely correct, but that doesn't necessarily mean that the taper has to be all the way to that size, all the way to the top. So if most of my cases are at least a size 30. They don't look like it because if my flute diameter, so the diameter of the actual file is very slim, just the apical third, like apical 3 millimeters, might be a 3004, 4004.
Okay, that's pretty cool. Yeah.
But the rest of it is going to be much slimmer. It might only be a millimeter maximum flute diameter.
Okay, that's great. That's awesome. And so I'm sure he'll listen to that and learn a lot from it. So the last question I have is from Dr. Freeman, who just came on the last couple episodes of the podcast. And his question was, with implants failing more in healthy patients, like we're starting to see especially with like maybe general dentists placing more and more implants, that there's like a slight increase in like implant failure rates as of late. Have you seen maybe like more trends towards maybe trying to save more teeth than to just extract and place an implant? Have you seen maybe more attempts to like endo treat some teeth that maybe in the past 5 years would have been maybe extracted and replaced with an implant?
Yes, I think that's in a combination of more and more advancements with apicos, as well as more and more understanding that of implant failures, not necessarily of the implants, not just of the implants having peri-implantitis or something like that, but also all the stuff that we see on Instagram where occlusal problems or implant hardware problems like broken screws, broken issues, that kind of thing. So yes, and I think yes in a lot of ways. So for a lot of those factors, and then also because we understand that since implants have a failure, that means that there is a certain length of time that we're expecting for an implant to do well for, right? A lot of times we're looking at a certain number of years. And so we sometimes want to extend that time or push it back a little bit. And
so I guess the age of the patient's like a big factor, right? Maybe like.
Exactly.
Okay, that's great. Because you would do the endo, and then even if it lasts 5 or 6 or 10 years, and then that just means that the patient has longer with the implant, like in terms of like their life cycle. So that's pretty cool.
Exactly.
And what about like, I've seen, I don't know about in the US, but in Canada, I've been hearing a lot of endodontists are actually placing implants. Like, what are your thoughts about that?
So I understand the rationale, and there are some endodontists, not very, it depends on the area, depends on the endodontist. Yeah. There are some who do it, and their rationale is that they see the tooth, there's a vertical root fracture, they're already in there, patient is already anesthetized. Who better to just place the implant while the patient's already there. My personal thing is that I am not anywhere nearly educated and trained anywhere near my OMFS colleagues, my periodontal colleagues, my pros colleagues. And on top of that, I see from all of our pros colleagues, for example, on Instagram, discussing all the time how restorative principles are so important in deciding even where
it
to
drives
put
the placement.
Exactly. Mm-hmm. So for me to then place an implant right away after attempting endodontic treatment, let's say I see the tooth is vertically root fractured, I wouldn't even know where to start with the restorative treatment, because like that means you'd have to how does the general dentist or the restorative dentist even know exactly what the restorative is going to be, because they haven't evaluated that. Yeah, they haven't evaluated that tooth with that treatment in mind. So for my philosophy, it's that I would much rather stop my treatment, stabilize the tooth, and not extract it just yet, because that way the patient can return to their restorative dentist, have all the restorative planning in place before extracting the tooth. So that way they can decide whether or not an immediate implant is the best option, whether a extraction and bone graft is going to be the best option, whatever it is. So that way they can do all the planning ahead of time. I'm very much for making sure all of my everything is in order before deciding that. So that's my personal philosophy on it. But the people who are educated and trained enough that they feel comfortable placing implants, I mean, that's okay. I just don't personally feel as comfortable doing it. And additionally, it's a lot of materials and a lot of things to have around. Exactly. So if they can have it where they're doing it as high of a level as our surgical, periodontal, and pros colleagues, I mean, that's great for them. But I would not have those available, so I don't have
That's
those.
Awesome. And so one last question I just had before we wrap up here is, how often are you using like CBCTs in your treatment planning or as a diagnostic tool in your cases that you're doing?
So CBCTs are a great tool when you need them. In my practice, we're having one installed very soon. So I currently don't use them in my practice. That because I don't own the practice, I work for somebody else for that. In residency, we had access to it all the time, but CBCTs are great as an additional, like an adjunctive. If it's something that you can't see through the PA, and that's what the AAE has recommended, that it's for certain situations that you can use it all the time, and then certain situations you have to see whether or not you need it. So for the cases that they've already advised using it almost as a first route right after the PA, and you always take it, is cases of trauma or invasive resorption. And then obviously if you're planning for an implant, those are some times where you're definitely going to take one right after taking the initial radiographs. But they're absolutely invaluable for situations like planning an apigo. Pretty much you have to plan, because they're just like how you plan for an implant. You want to know exactly where everything is. Same thing, they're great for an apigo. Additionally, they're really nice to have for a retreatment, because that way you can locate exactly where a missed canal might be, as well as using them to see if how extensive the existing treatment is. Are there any strip perforations or perforations? Are there any separated instruments or canal transportation or anything like that?
Yeah, that's perfect.
Yeah, so it's really great for a lot of ways.
Awesome. Thank you very much. It's been like an amazing episode. I think, I learned a lot. I've been writing down a lot. I think I might even type up my notes and share it in the show notes, because like having an endodontist kind of go through like step by step how you do a root canal is pretty invaluable and pretty cool. So I really want to.
Oh, really? Yeah. I'm glad. I was worried that I like just bored you.
No, not at all. I mean, that's like, I mean, I think that's where I want this podcast to be, right? People come in, get relevant, like actionable information. Like, it's not always about like, like doing this or doing that, but it's just like, what's the basics of like steps of a root canal so people can maybe see what you do and maybe like change it up a little bit or learn a thing or two, which is what I've done just now. So I really want to thank you. And I thank you for answering the questions from the people on Instagram. So Dr. Stephanie Tran, Her Holiness the Pulp, which is a fantastic name as well. So I'll tag you in the show notes as well. So hopefully people can reach out to you if they have any questions or anything like that. And hopefully we'll do another episode sometime down the line.
Yeah, that'd be great. Thanks. Anytime anybody have any questions, feel free to contact me. They can always contact me through Instagram and my other social media. So I really appreciate it. Awesome. Thanks. I appreciate you having me on here. I really enjoyed chatting with you.
My pleasure. Thank you. Have a good night.
Take care. Thanks. You too. Bye.